All right, welcome everybody. Thanks for joining us. I see quite a few of you signing on here. We're excited to have you for this very first edition of our Voices from the Field virtual panel discussion. Thanks for joining us right on the dot. We're actually just going to wait another minute or so to allow people to join. So just hang on the line for a second, and we're looking forward to getting started. Okay, so for those of you just joining us, thank you again for taking the time to join us. My name is Amy Donahue. I am the Manager of Communications for Pivot, and I just have a few housekeeping things to say before we get started, and at that point I'll hand the mic over to our directors, Tara Lloyd and Matt Bonds, to get us started. So just a couple of housekeeping things. We are going to try to reserve the last 15 to 20 minutes of this hour for a live Q&A. You should feel free to go ahead and type any questions that you have into the Q&A box down at the bottom of your screen if you're joining on a laptop. But when we get to that portion of the call, we are actually going to try to take questions live. So if you would use the function that says raise my hand, which should be on the right side of your screen, we're going to do our best to call on people so that they can unmute themselves and actually ask questions to panelists with their voices rather than via the chat box. And the only other thing I'd like to mention is we are intending on holding these weekly for the foreseeable future. Topics will be focused likely around COVID-19 until things have shifted, and then we hope to carry this forward thereafter with new topics. So we didn't get the chance to set up a registration mechanism this week. So if you could do us the favor of shooting a quick email to info@pivotworks.org to let us know that you attended today, that will allow us to follow up with you accordingly. And while you're there, please feel more than welcome to provide any feedback or suggestions for future topics. So with that, thank you again for joining us. I'm going to turn my video off and hand it over to our Executive Director, Tara Lloyd, to get us started.
Good morning or afternoon or evening, wherever this webinar finds you. It's my pleasure to be a part of this today and to introduce you to our field team. One of the silver linings, I suppose, of the situation the world is in right now is that we're all better at virtual connection and video than we've ever been. So this is like a uniquely amazing opportunity to talk to Dr. Njaka and Laura, who are in the field in Ranomafana. Maybe you all can just wave. They are our frontline responders, and Dr. Alicia Mayfield, our Chief Medical Officer, who's in Seattle. The three of them will be our panelists today. And Matt and I will moderate. And as Amy said, this is brand new, so bear with us. Hopefully the technology will be great and you'll feel more connected than you ever have to Pivot. But if we blunder, then please excuse us and raise your hand and interrupt if we start using acronyms that don't make sense or describing places without fully explaining what we're saying. We really want this to be a conversation. And a dialogue and a chance for you to sort of put yourself in the shoes of the people who are responding in Madagascar in a way that's never been possible, right? I mean, at least in my lifetime and all of ours, we've never had a moment like this in the world where people who live with the kind of fragility that is commonplace in rural Madagascar, food insecurity, water insecurity, you know, all of the mortality rates that we talk about so commonly, children not living past the age of 5, that sort of thing, that's not normal for so many of us. And often I think of the Pivot International team as a bridge to that world. And now all of a sudden we're all facing fragility and this sort of collective moment of action and understanding our connectiveness in the world in a different way than we, I think, ever have. And for those of us that do global public health work, our work has never been more central to the world's dialogue. I don't think I've ever had as many neighbors while we're all walking 6 feet from one another in the street ask me about it. And so I'm hoping that this is an opportunity for people who've chosen to join today because you care about Pivot, because probably you know one of us, to listen really in a new way to what it feels like to be in Njaka or Laura or Alicia in the response that we're preparing for in Madagascar. And Matt and I will try to be the anchor and the bridge and listen for the questions that could lead us into deeper conversations in the weeks to come. So I think that's all I want to say in opening. I'm going to have Matt offer a few opening remarks as well, but there is sort of one little clarification that I notice we slip into sometimes, which I'll just say now. So Ranomafana is the name of the town where Pivot works, where the national park is, and that is within the district of Ifanadiana, which is also the name of the town that is the capital. And we use those words kind of interchangeably. And whenever we say any of them, we're talking about our field site and the response that is happening on the ground with the 211,000 people that are in our catchment area. So if we do things like that and you get confused, please stop us and raise your hand. And with that, I'll hand it over to Matt and ask him to give some opening remarks.
Thanks, Tara. So I'm actually coming at this from the perspective of an epidemiological modeler and trying to understand what's going on in the world with this emerging disease, what that means for everywhere in the world, and what that means for the nation of Madagascar and in our district. Before I say that, I might, recognizing that maybe there are a few new people in this audience, I'll just share a couple words about what Pivot is in case some of you aren't aware. So we're a non-governmental health organization that is working with the government-provided model health district. We work at all levels of that system, as people will talk about later. And we are particularly connected to the relationship of data and rapid response health service to both improve the system for the long term, but also hopefully respond quickly. And this is just an extreme version of what we do routinely. So I just want to share a few words. We're all following the epidemic closely. It's a very confusing situation because it's moving so fast. So I'll give a really quick overview, a little bit of an idea of how the world is making predictions of what's going on and what that might mean for where we work. So the first case of coronavirus was detected at the end of 2019, December 31st. The first death was in Hubei in China, January 23rd, and at that time, they put a quarantine on the city and then the province, the city of Wuhan. So around that time, January 20th, is when the world started finding cases everywhere. Not a lot. I think our first case in the U.S. was about then. So where we are right now, since that first case 2.5 months ago, is there's been globally, as many of you are probably following, over 450,000 cases. So 20,000 deaths since that first one, detected just a month and a half ago. And that's going up about 2,000 per day globally. So a lot of people compare COVID to influenza as just a rough approximation and are asking, is this like flu? What's different about this and why do we think it's different? So I'll just say a few things about the challenges and what we know. So the first challenge is that the situation is changing rapidly. We're at the beginning of the epidemic. So we don't know how this curve works out. Flu is something that is super well studied and well modeled. The other challenge, as we all know, is there's massive underreporting. Tests had just been developed recently, and most countries don't have them at the level they need. And then the third thing is that there's big time delays between everything, between the infection, the onset of symptoms, death, and then time delays on the effects of policies. So because of that, we have to rely on a combination of conjecture, composite images from the world, and mathematical modeling. So just quickly, a few things that are important to keep in mind about COVID is that the first thing is that it's a novel virus. What's different about flu is that we haven't had it before. So we don't have any known innate immune response to it. So that means it's deadly. And the early estimates are that it is maybe 10 times deadlier than flu, maybe even 30 times deadlier than flu. Those numbers have come down significantly as the evidence has come in. It's looking more likely to be 2 to 3 to 4 times deadlier. It's also more reproductive. So each individual who is infected passes it on to the second person. Some part of the vernacular that is now common in the world is the term R naught. That's a really common term in epidemiology. It's the basic reproductive ratio. It's how many new infections there are from the first individual in a completely susceptible population. So COVID, it looks like that's about 2. So that results in exponential growth. That's higher than what we see for influenza. So I'll just share a few numbers and then hand it over. So this is important because of the lack of evidence, it means that we relied heavily on models. So the first good models of COVID came out, as far as I know. There might be earlier ones that are around March 12th. So the Ferguson group from Imperial College, experts in influenza, have extremely good models, though the parameters for this particular disease are tricky. They estimated that 80% of the US government would be infected. I'm sorry, 80% of the US population, and that would lead to about 2 million deaths. It was the next day that our government created in the US a national emergency. So those kinds of numbers have changed. We know more about the reproductive rate. We think it's lower than they had relied on based on early evidence. We think the death rate is lower. But even then, my own back of the envelope calculations from the literature that's coming out every day is we're looking at, in the United States, without a response, about 350,000 deaths. So that's 10 times what a bad flu season would look like. So just we have seen some countries get control of this: China, South Korea, Taiwan, Singapore. In the US, we haven't seen that yet. We haven't seen things come under control. It has taken 2 to 3 weeks in some countries. So in Madagascar, just quickly, what's different? Madagascar is a very different age structure. It's a much younger population. Only 3% of the population is over 65, compared to 23% is over 65 in Italy. We don't know if that's going to have a big effect on the distribution, but it probably does. On the other hand, we have way higher levels of acute respiratory infections in general, tuberculosis, various forms of pneumonia. There are big burdens of disease in general. So we don't know if that'll exacerbate or dilute what the consequences would be. And of course, hygiene and other kinds of issues are just way more issues. Just clean water. In our own district, half the population doesn't even have a latrine to use when they defecate. So those are kind of the situations that we're looking at. So we're looking at 50,000 people maybe would be infected based on these kinds of calculations in our own district, 10 million in the country.
Thank you, Matt. Okay, so as we transition to our panelists, I'm gonna remind everybody who's joined we're not calling it a webinar, we're calling it a conversation, who's joined the conversation, that we're gonna try to have the 3 panelists tell a story about what it feels like to be a part of this. And those stories have moments of joy, even though that may sound surprising, real moments of uplifting things that they're doing for one another, or we're seeing members of our community do, and of course, moments of struggle. Because we have, as an organization, responded to plague and responded to measles. Some of this is our core business, and some of it is new. And because we're a government partner, some of it is our decision and some of it is not. So you're going to hear a little bit of all of that from the panelists, and they're going to each speak for about 5 minutes, and then we're going to try to stop and take your questions. So if you're adding that up in your head, you're thinking that's an extra 10 minutes, but don't worry, we are time optimists at Pivot. So we will accidentally blow through that, but we're not going to blow through the hour. So you will get back to whatever you were doing at 1 o'clock. And the last little bit I'll say is that I know lots of people have kids home and kids in the background, and I do too. And the babysitter is under strict instruction that this is the hour of all hours to stay downstairs. And I hope they will. All right, so Laura and Njaka, you guys are up first. I'll hand it over to you.
Great, thank you so much, Tara. So I'm Laura Cordier, Pivot's country director based in Madagascar. So I wanted to talk to you all about our response at a national level and how we're supporting the Ministry of Health in Madagascar. So the first case of COVID-19 was announced on March 20th, last Friday. As of this morning, there are 19 confirmed cases. 450 suspected cases have been tested, but there's still more than 1,000 suspected cases to test around the capital, Antananarivo. New cases are obviously being identified every day and slowly but surely decentralized at the different provinces. So Pivot is supporting in two ways. At the central level, which means with the Ministry of Health in Antananarivo. So our technical counselor is an active member of the Disease Surveillance Committee and is part of multiple subcommittees. So Pivot has the ability to support on supporting the government with clinical care guidelines and flow charts for patients, and also on logistical support. We are also obviously very involved at the implementation level, which is unlike many other organizations. So at the local level, I want to present some of the nuances of the frameworks that we're working in. As Tara mentioned, we're not always in control. So the Ministry of Health in an epidemic response is a technical partner, but actually the local authorities, the government officials and elected, I would say, counselors are the ones that are making decisions. So Pivot is supporting district level committees, subcommittees on health as a technical partner on providing advice on clinical protocols and preparedness, and really supporting the response logistically and just also on a technical front. So the nuances of how the Ministry of Health and local authorities make decisions is very complex, and it is being intensified and amplified by the fact that coronavirus is a pandemic. The level of stress is increased, and it's creating a bit of uncertainty sometimes in terms of how fast we would want to respond because of who is the final decision maker on something that can be as simple as where does one refer a patient. Everything is changing every day, and everybody tries to reassess their position in this whole scheme. So as Tara explained, this is not the first time that Pivot has supported Ifanadiana District and the government of Madagascar in an epidemic and in a response to an epidemic. So in 2017, you all might recall there was the plague outbreak in Madagascar. In our district alone, we had 22 suspected cases in over 5 communes. Last year, there was a measles outbreak that also impacted multiple countries in the world. In our district alone, we had close to 5,000 cases, and we supported mass vaccination of up to 70,000 children. Coronavirus is different. It's different than plague. It's different than measles. And it's different in the sense that we're no longer the odd one out. We're no longer the odd country that has plague and that is supporting plague. And people are like, what? Plague? Madagascar? Coronavirus is a pandemic. So we are in a unique situation to understand trends in other countries, see how they could apply to Madagascar, especially as aligned with what Matt was saying. And so it's very different for us. We're in this kind of vacuum space where we can still make critical suggestions and critical decisions based on other countries' experiences. But there's also a lot that we don't know, and there's a lot of speculation, and it's very complicated. It's very different to what we've experienced in the past as an organization. Something that's been unique in terms of our response at a national level is we've never had such a say and never had such an opportunity to support specific guidelines and recommendations because our technical counselor is a key member of the Disease Surveillance Committee. So this is all very unique and very different for us. As an organization, we've had to completely shift our organization, our response. So all of our clinical staff has been completely redeployed to the field. They're shifting focus from specific programs to being a clinical staff supporting on COVID response. We're running at a reduced capacity at the office and have divided critical, essential staff. And we're having to think about different scenarios. So our logistics and our organization is ready for scenario 1, 2, 3, 4. When can we not cope anymore? So this is all, again, unique. I realize I'm already at the 5 minutes, so I'm going to wrap up and talk about some of the challenges that we're facing in terms of our framework of response. We're really being faced with having to find a balance between respecting systems and procedures of local authorities and who makes decisions, and also moving forward so that we're ready to prepare the health facilities and that we're moving forward as fast as this epidemic in terms of providing the best possible care for patients in Ifanadiana. So a final note, though this is all very challenging, the situation is changing every day. We are, the level of stress is increasing, the tension is tangible, the anxiety at the community level is real. One moment of hope for us and of positivity is that this is going to strengthen our collaboration with the community that we serve, with the government, with the Ministry of Health. We're there through thick and thin to support health system strengthening, the COVID response, and it'll make us a stronger organization in the end, despite all of the challenges. Thank you.
Thanks, Laura. So as we hand it over to Dr. Njaka, I'll just remind the audience around the world that Laura and Njaka have probably been at work for 12.5 hours now. It's 7:30 p.m. in Madagascar. I don't think that they took a break and got any dinner before they took this conversation. So we're thinking about you guys. Dr. Njaka has young children at home, and this is, this is a special thing to stay this evening and to talk with us. So we're really grateful for 6 years of service and now for 12.5 hours on a Wednesday. Dr. Njaka.
Thank you, Tara. My name is Njaka. I'm a medical doctor, manager of the Infectious Disease Program, and I have been with Pivot for 6 years. I would like to talk about our responses at the district level. Our district, called Ifanadiana, is composed by 21 health centers and 1 hospital. And I want to mention that only 6 of those 21 health centers is accessible by car. And our response, we have 3 main responses. The first about the sensitization and health awareness. And for that, we work closely with the community and the local authorities to make sure that people understand the coronavirus. And we teach them what to do if they have symptoms. We say to them the symptom and especially the precaution measures like social distancing, hand washing, and the second response is the preparedness and readiness at the health facilities and hospital. And for that, we are training the clinician of all of these 21 health center and hospital about the coronavirus, the symptoms, the clinical protocol, and the guidelines, and the precaution measures, as I said before. We are setting up triage to identify suspected cases and to reduce transmission of the coronavirus at all of these health facilities and hospitals. We support with protective equipment and infrared thermometers. We support with consumable and medicines. The third response is to set up of a health checkpoint at the entrance of our district. And for that, we are deploying staff, specifically clinical staff, to support the staff of ministry to make sure this health checkpoint. And we are making a specific equipment to make a health checkpoint effective and efficient. That's the three main responses in general. And I would like to share our challenge at the field. First is the lack of equipment. I mean medical equipment and protective equipment. And I think the main challenge is the unknown, the unknown of coronavirus. And that's for Pivot, that's for Ministry of Health, and especially for the community. And the third challenge that I want to say is the unavailable of rapid test. So thank you.
Thanks, Dr. Njaka. Njaka's job changed pretty dramatically because of COVID, just to say it out loud. He's our manager of infectious disease, but he's been designated the point for this response. And so a lot is riding on him, and we're really grateful. Alicia, we will go next to our Chief Medical Officer and have her words.
Hi, everybody. My name is Alicia Mayfield. I'm the Chief Medical Officer for Pivot and started in July of last year. I'm going to apologize in advance because I do have a cold and I blew my nose before we started, but I don't think it's sufficient, so I'm going to be sniffling. So I think you've already heard from the most key people, Laura and Njaka, and you got some good framing context from Matt and Tara. So I'm just going to add a few things, and then of course, like, we're all available after this for any questions that you have really on anything, whether it's what we're doing in Madagascar for COVID, what we're doing in Madagascar generally beyond COVID, or just what you're seeing here in the United States around COVID. So one question that I'm hearing from a lot of people, and this ties in with what Matt was talking about, is how does this pandemic compare to other epidemics that we've seen in the past? And I think we're still very early in this, the evolution of this pandemic. It seems already like it's been a very long time, because this has been quite intense for many of us, both here in the United States and in countries around the world. But it's looking like potentially this is going to be the most significant epidemic we've had globally since the 1918 Spanish flu. So really in the last century. We're hoping that due to our much more established and comprehensive public health and healthcare systems, that we can mitigate it and not have the same impact that we saw with the Spanish flu, which had tens of millions of deaths, unfortunately. Matt already mentioned the amount of cases we're seeing globally, and as we all know, we know about 500,000 cases right now, but odds are there are many, many more cases out there that are not yet identified, and many more people that are just now starting to be infected or will soon be infected in the near future. So it's really a rapidly developing situation. I think one of the things that is most important now, and that we're trying to focus on here at Pivot, is how do we learn from the lessons of other recent epidemics? So looking at things like Ebola and cholera. And our team is lucky enough, as Njaka has described and Laura described, to have experience with addressing highly infectious outbreaks of things like plague and cholera locally, we also have experience kind of more broadly, and I have experience personally. I think you all just saw my cat, so apologies for that. It's one of the things about working from home. I thought if I locked her outside, she would meow during the whole conversation. So anyway, I think, you know, we're trying to learn from Ebola. What are the things that were done well and were not done well? And I think there are three main lessons that I would take from Ebola. One is the importance of case identification. So that's looking for people who might have symptoms and testing them as quickly as we can. The second is containment. So that's once you have identified cases, putting them in the hospital if they're very sick, isolating them as much as possible. If they're not too sick, if they had mild symptoms, having them stay at home so that they're not spreading that infection to other people. And then the third piece is mitigation. So I think many of you may be getting a lesson in public health right now, whether or not you work in healthcare or public health. But the idea here is doing contact tracing. So if I'm infected and I'm working with Laura and Njaka in the same place or coming home to my family, looking at all those people I have had close interactions with and finding out, do they have symptoms, making sure they stay home, they're not spreading it to other people. Because as we know, this infection can, people can be infected and not have any symptoms for a period of time. And unfortunately, the early days right before a person develops symptoms is actually one of the times when you're most infected. So the first few days before you develop symptoms, and then the first few days after you develop symptoms are when we think people are most infectious. So how do we do those things we've been hearing about, like social distancing, keeping people apart so that we, this is another public health term, flatten the curve. The idea there is keeping people at home so that they're not spreading the disease. And even though we know over time that a large percentage of our global population, both here in the United States, in Madagascar, and in other countries around the world, will probably be infected with this illness. What we want to do is slow that process down so that we are not overwhelming our healthcare systems. I think we've all seen what's happening in Italy and how dire that situation is when so many people get infected and really sick at the same time. Even a very strong public health and healthcare system can't handle that. So my primary concern in this situation is we've seen how difficult this is to control here in the United States and in other very developed countries. We know that places like Madagascar have already weak healthcare systems. It's difficult to implement public health measures in these settings, and they have weak supply chain systems. And so I'm worried it will be that much harder to address this pandemic in the setting where we're working in Madagascar. The thing that gives me hope is that we had a little bit of lead time here, not as much as I would have hoped or liked, but we were able to see this epidemic spreading to other countries, learn from some of the experiences in other countries. 10 days before we had cases in Madagascar, we started doing things like ordering personal protective equipment, those masks, gowns, gloves, et cetera, to protect our healthcare workers. We ordered 7,000 tests. We ordered a supply of additional oxygen concentrators for those people who will need oxygen support in the hospital. As Njaka mentioned, we've been working on guidelines. We've been supporting the government closely to help them be prepared. You know, I think one of the key differences between an organization like PEVIT and maybe one that people are more familiar with, which would be Doctors Without Borders, is Doctors Without Borders is able to go in an acute emergency like this, set up a whole new hospital, hire their own people, set up their own systems. And that's great in that it's rapid and it's effective, but there's some key things that are missing there that we have that we can build on. We're already there. We already know the people. We already know the systems. And we're working in a public healthcare system, so everyone can access it. They could access it before this happened, and we want to make sure they can continue to access needed services beyond COVID services during this epidemic. So I'll just close with I was really struck last night. I was watching the news, as I'm sure many of us are right now, if we're not in Madagascar. And I saw an interview with Senator Ed Markey, and he compared this to, you know, there's been a lot of people talking about, we need to mobilize here like this is the Second World War and move over our manufacturing systems in that way. And he said, this is our next World War. And that's a pretty dramatic statement, but I think the good thing about this is it is a fight that we're fighting, and it's a fight that we're all in together, rather than previous world wars where we've been fighting against each other. And I think that, sorry, I do get a little bit emotional about this scenario because I've been spending a lot of time thinking about the impact that this could have on our staff and all of our patients. So, but I think the really important thing is to understand from this how connected we truly are. We see cases spreading from China to the US and Europe. We now see cases spreading back from the United States to China. And, you know, it just underlines how much we need to come together locally in our own communities, nationally here in the United States or in Madagascar, and globally, because if we don't support each other to address this effectively in one place, it will spread to another place and then spread back. So I'll close with that we're really all in this together, and so appreciative of you being in this fight with us. Thanks.
Thank you, Alicia. We have 67 people spending their lunch hour with us. I'm sure you've all just been struck by what an incredible team of people we have. If we could invite you to meet all 181 of our Pivot staff and our government partners, we would do that too. Maybe that will be next week's. Before we turn it over to questions, I want to share one standout story to me of hope, well, and just of what Alicia is saying about solidarity. So last, I think July or so, there was a little girl named Elisa who was 4 years old at the time, who was brought into the government hospital by her father. She had a tumor that Alicia could explain better than I, but I'll just give you the sort of layman's term. It was growing on her face, and it was beginning to restrict her breathing and her ability to eat, and her family wasn't sure what to do about it. And she was brought into care a number of times, and when she finally crossed paths with Pivot and the Pivot clinicians, her case was elevated. And over the last year, we've been deeply involved with Elisa, and she had surgery in the capital city of Madagascar in Tana, but there wasn't enough that could be done at that level. And so with another NGO that does this sort of support, we evacuated her to France, and we reached out to our Pivot family, and we asked if anyone could host her. One of our staff members has an aunt and uncle there who agreed to host Elisa for what we thought was 6 weeks. And then we quickly needed a staff member from Pivot to be her accompagnateur, is what we call it, the sort of person who would go and be with her. This required getting passports and visas and figuring out the funding, and her very rural family, who had not previous to this left their part of our district, was now faced with this decision of letting their daughter go and not being, as parents, able to come with her because of their responsibilities to their other children and to their farm. And so our nurse, Miora, went with Elisa again for what we thought was 6 weeks. And I have beautiful pictures from Christmas when Laura went home to see her family and met with the aunt and uncle and Miora and Elisa. And you can see Elisa over the weeks sort of looking fairly scared and then starting to look really happy. And then you start to see the aunt and uncle holding her, and you start to see these beautiful smiles, and you can see she's just relaxing into to this world. And we kept checking in with Miora, thinking, you know, hopefully she's okay in terms of the responsibilities that she's left at home behind. And as the surgery becomes more complicated, and we may have to see them stay longer, is she going to be able to stay there as a accompagnateur? That's all pre-COVID. Now the borders are closed, elective surgeries are not happening, and we don't know what is next. And so I reached out to the aunt and uncle and said, I just want to check in with you all as supporters who thought you were taking in something like a foster child for 6 weeks, and now it might be months or longer. And they have just been so incredible about the whole scenario. In fact, maybe they're on right now. They basically just said, this is our new family. We are a family of 4 now, and we are in this together. And we are bringing in Elisa's parents to our office and connecting them through Zoom calls like this to their daughter in France, and using these technologies that 20 years ago when I was a Peace Corps volunteer, we could never have imagined actually seeing people at home from our posts in the field. And now that's how these parents are staying in touch with their daughter and believing that we will get her through this, that elective surgery will open again in France, that she'll be able to have the next stage of surgery that she needs, that the necrosis she's suffering from now will not get worse. And that's the sort of thing Alicia is also following, and Lauren and Njaka and everybody, in addition to what our COVID response looks like. So moments of new families forming and supporting one another and helping perfect strangers abound. So I'm sure that's true for you and your neighbors as well. Okay, so it's 12:40 here, and we're going to turn it over to your questions. We've had a couple come in through the chat box. So we had thought that we would like to have people ask their questions directly, which I still think would be nice because I'd really love to hear your voices. So I'm going to call out the first question that came in and ask to have you ask this question. You can if you're able, and if not, I'll read it for you. But it's the person who asked about people who live day to day already, people living in extreme poverty. If you ask that question, could you say it aloud and we'll figure out who's best to answer it?
All right, the user is D2P, and I'm about to allow you to talk. So go ahead and take it away.
Hi, can you guys hear me?
Yeah, yay.
Fantastic. So my name's Dan. I didn't know if this was a real thing, hence my kind of weird screen name coming in. I'm actually here in Tamatave, Madagascar. I saw this just randomly on a RPCV of Return Peace Corps Volunteer post. So thank you for this conversation. Since I have you, I want to do 3 questions, 2 kind of regarding COVID, and then 3rd about this insecurity. I'm guessing maybe Matt, you'll be able to answer this, but what's the latest news on people that have been infected and then have kicked it? Are they creating internal immunity, or can they be infected again? First question. 2, timelines that we've heard on the news regarding any sort of vaccine could be anywhere from 12 to 18 months out. Is that true? And then if so, how do you envision that such vaccines will be given to developed countries versus developed? And then the 3rd question, which I listed there, is based in Tamatave, which like the capital Tan is in lockdown right now. I foresee that there's going to be bigger security issues, more so than the disease, because so many people work day to day, and if they can't feed themselves, they're going to have to find other ways. So those are my 3 questions. Thank you.
Thank you, Dan.
Thanks, Dan.
So we'll start with Matt. It sounds like the first 2 questions you thought Matt could maybe best to answer, and then the question around food insecurity and lockdown, I think I'll hand over to Lauren and Jack. Matt.
Hi, Dan. It's great of you to call and engage. So there's no evidence that that people will lose immunity once they acquire it, once they recover from the disease. So all conventional wisdom and all evidence points to an acquired immune response. So that's what we would expect, unless something else counter to that occurred. Alicia can probably add anything to that if she would like. The vaccine, I'm following the vaccine story like everyone else. I don't develop vaccines myself. We don't run clinical trials for vaccines yet in places where we work. But so I know kind of what everyone else knows from that, which is that there's, I think it's a 12-month optimistic time frame for vaccines that are developed and able to be deployed. If
Okay,
Alicia,
Lauren and Njaka, how about food insecurity and basic day-to-day security for folks in our rural areas?
No, absolutely. So thank you for that question. Obviously in cities and rural areas, I think it's going to be different tensions. In terms of security, I think our approach is going to be, we're collaborating with the government, we're collaborating with the gendarmes and the militaire who are very involved in the COVID response, and we're hoping that close proximity in terms of trying to manage the situation as it evolves every day, really highlighting the fact that COVID is affecting all nationalities and all people, to be able to kind of reduce the tension in terms of stigmatization for certain individuals, whether it's tourists or residents or even Malagasy who've traveled in the past. So that's very much on our mind. And then for sure, procurement for food is something that we're very concerned about, and that as an organization, we're thinking of different scenarios. We know for a fact that the government is trying, at least in Tana, to already address this issue in terms of supporting the most vulnerable. Now that's going to be a huge task, because the Ministry of Health's response is going to be already one challenge, and supporting the most vulnerable is going to be hard. And so social support is part of Pivot's core mission, and so we will continue, and depending on how things evolve, supporting especially families that are in quarantine, that are self-quarantining. When you're 75% of the population is in extreme poverty, it's a big concern for us, and we're worried about the vulnerability that is going to be created for those individuals. And so we're really hoping and relying on this solidarity that is innate in Madagascar. We're thinking positive, and we're trying to support communes to feel safe, to feel together, and to really have a response that supports people who are in need, so that, if it comes to the point where, roadblocks are preventing procurement, or even big suppliers are reducing what they're offloading, usually, we hope to be able to go through this together. Now, I realize that a district and a rural response and that kind of network of support is very different in a city. So I realize the challenges between Ifanadiana districts and Tamatave.
The next question we have, I think, would be right for Njaka. If you are Dimbi and you asked a question about folks in the rural countryside, can you unmute and ask Dr. Njaka that question? There we go. I see Dimbi, but still on mute, I think.
There we go. Dimbi, you should have the ability to unmute yourself now if you'd like to ask your question.
Yeah, can you hear me now?
Yes.
Yes.
Okay, so hello everybody. My question is just about the understanding of the people regarding coronavirus in Madagascar. Do people in the countryside really understand what the disease is or not?
So Dr. Njaka, do you feel like people in the rural countryside understand the disease?
That's an interesting question. Thank you. As I noticed here from the beginning of this coronavirus, the people, especially for the field, they don't have like a television or internet connection or radio, so they can't understand very well what is that. But just like even I can say, we said coronavirus and they heard like cholera virus. So it's so different that I noticed when I said about the challenge is the unknown. And they don't know very much what is that. And we tried, it's true, we tried to do the sensitization, but here in the big town of Ifanadiana and Ranomafana, for example, the level of understanding is different than people from the field. And that's the difference for that.
Yeah.
Thank you.
Thank you. All right, we're getting a couple of different questions. Let's see if we have sort of a more general one. We've got reducing the curve. We've got cases in Tana and Tamatav. Seth, let's ask yours. Seth Cochran is on the line with a question about our region, which is called Vatovavi Fitofanani, and that's the abbreviation. Seth?
Thanks so much. Thanks for doing this. This is really awesome. Just to have you guys put this together and have a conversation like this and get information. So we work in Madagascar and we're partners with Pivot, and we've heard from different sources that there are cases in both Tomasina and Tana, and that they're shutting down all of the roads to keep people from moving. Particularly in Tomasina, we have a big fistula treatment center there, and we know that there's probably cases there, and so obviously we wouldn't want to send any patients there until this calms down. But what we wanted to know is what you guys know about the distribution of cases in the country, and if there are any in the region in Vatovavi Fitfanan.
Let's have the folks, Lauren and Jack in the field, answer that.
Thank you, Seth. I'm so glad you were able to join. So it's a complex question what you're asking me. I would say what we know is what you know in terms of confirmed cases. Right now, well, we'll wait the address, or maybe the president has already announced the newest number of cases confirmed. I can't say for sure, but till this morning it was 19 cases confirmed. We can't say for now that there are confirmed cases in Vatovavi Fitfanan. We wouldn't even have the capacity to talk about confirmed cases since we don't have diagnostic capacity. I'll return to what Njaka said. It is our biggest challenge, and not just for ourselves in Vatovavi Fitfanan, but for the rest of the country. We don't have yet the capacity to be able to send samples, and there's no rapid testing. So right now we're just working with suspected cases. And a barrier has been set up, and that's where suspected cases are potentially being identified and referred to Fianar at the CHU Andriambolamanana, but no confirmed cases in VZV for now.
Thanks, guys. We've got a question from Ian that I think is right for Alicia. Ian, if we could unmute you and have that question, please.
Sorry, which question of those would you like?
Oh, you can ask them all and let Alicia choose. I was thinking the ethical question, but all good.
Thank you. Yes. So one of the things that we talk about with social distancing is about flattening the curve so that the healthcare capacity is not overwhelmed. And having been to the hospital in Ifanadiana and seeing what the capacity is there, I'm not particularly optimistic about how much there is. And so I'm wondering, when the hospital becomes overwhelmed, do you have an ethical framework for how you're going to allocate care and distribute resources?
Yeah, thanks, Ian. That's a really good question. And it ties into a little bit what I was just thinking about, part of the response to the last question. I think what you see in scenarios like this is twofold. You have, or maybe threefold actually. You have people coming in because they're scared, because they've heard something's going on, they don't really understand it, and they come in for any number of reasons and maybe don't even really need that care. And that kind of clogs up the healthcare system. Then you have the people coming in with COVID-19, related symptoms who we want to see and need to see. And that can be overwhelming to the healthcare system depending on how many of those people there are. And then the third thing that you have obviously is your baseline health problems. The previous speaker was asking, or question was around people who have fistula and where to send them for care. And one of the things that we really saw in Ebola that if we can, we want to try and avoid is we saw a lot of unnecessary maternal deaths. Any woman who came in with fever and bleeding and pregnancy was turned away from many of the hospitals in Sierra Leone. And a lot of women in normal pregnancy have fever and bleeding. And so what that meant was you had a lot of unnecessary maternal deaths, and then you had a lot of children with malaria and all the routine things that people suffer from every day, not being able to access care. And so what we've been doing is looking at how do we set up hospitals and health centers in the regions where we're working and provide the governments for other regions, the government officials, with information on how to set things up so that people who need regular care can still receive it safely in designated wards. People who are suspected COVID cases can safely receive care in one area, and then people who are confirmed cases, once we do have that testing capacity in place, are isolated, and they're not, healthcare workers are not spreading infections amongst them. Laura referenced this a little bit. We're looking at scenarios also, what's our normal capacity at these health centers and hospitals? What happens if we get twice the number of patients we normally see? What happens if we get 300% increase in the number of patients we see? So we're planning for that. There's certain things you can do. We can work on how do we really mobilize our community health workers, allow them to do safe contact tracing and awareness raising in their communities, keep people potentially, if we are getting overwhelmed, have systems in place so that we're keeping people at home if they're not really sick, and then only bringing people to facilities if they are really sick, looking at putting in additional screening and security so we can kind of weed out who those people are that really need care and triage them, and then other people potentially will have to wait or come back for care at a later date. The real bottom line answer is, there are ways that we can manage certain amounts of increase, and then there is a point at which the system just can't manage that, and that's what we're seeing in Italy right now. And so the more that we can work with the government on containment measures earlier, the better, so that we don't get to those points, hopefully, but we just don't know.
I would like to add one comment, especially just on this last thing you just said, Alicia. Really, that's going to be the key for us, is just to clarify for the community that is listening to this conversation and who is part of this conversation. It is not Pivot that is deciding, when the hospital is going to be at full capacity or when it's too much. We're really in partnership with the Ministry of Health, with the district health officials, with the regional health officials. I mean, we're on the phone every day. They're calling us right now on the phone. And so we'll get there, and we are going to plan and prepare those different scenarios with them. And that's going to be really key. And if the hospital gets overwhelmed, maybe health facilities will be redeployed and used differently all the time, making sure that basic services, primary care is available. So today alone, there were referrals of women with complications for delivery. That's not stopping, and that's really important. We're never going to be thinking about, we don't want to prioritize certain people. We always want to be ethical in the way that we're providing care, but support that, thinking about ethics in care, especially in this nuanced and new world that we're in with COVID.
Thank you. And Ian, that makes me think, if you're someone who has an ethics background or a framework to offer us, this is another reason that we hosted the call today, is just a call to supporters to offer anything you can. If you do have advice for us, please engage afterwards. Amy mentioned that info account, which is a way to reach any of us, or specifically our addresses are on the website. If you're trilingual and you like to translate documents, we sure have a lot of health documents in the queue ready for translation. There you go. Yeah, if you're an economist and you want to talk to me about trigger points and organizations and whether I should shrink right now because funding is drying up, or grow because the world cares about global health, please reach out. We're in uncharted territory in some ways, and then in very charted territory in others. But Amy's going to close up with a little bit of housekeeping, and then I'll just say a word as farewell.
Thanks, Tara. Thank you again, everyone, for joining. I just wanted to say quickly, as I said at the top of the call, but for those of you who have joined us later, if you wouldn't mind, please just shooting us a quick email to our info account that Tara just mentioned, info@pivotworks.org, so that we can follow up with those of you who joined. We promise not to inundate your inbox. We'd just like to know who made the time to join us today, and so that we can invite you to join future talks like this, which we intend to hold weekly for the foreseeable future. So if you could just shoot an email saying I was there, and like I mentioned earlier, any feedback, we're more than happy to hear from you, as well as ideas for future topics for this virtual panel. So I'll hand it back to Tara, but thank you everyone for joining.
Beautiful. 1 o'clock on the dot. So I'm just going to say farewell. Maybe in Njaka and Malagasy, you could say something lovely and farewell and thank you, so people can hear the right language right now. And just to all of our supporters for being on the line, we really appreciate that you made time for this. And if you enjoyed it or you learned something, please invite your family, your loved ones, or friends to join us next week. We'll keep this going, and we're really, really grateful for the point of connection and the solidarity as the world faces this together. Dr. Njaka, closing words.
Misauta Betsaka. That's mean thank you so much. Misauta Betsaka.
Misauta Betsaka.